webinar. I'm Joyce Coleman, Executive Director of the Vasculitis Foundation, and I will be moderating today's webinar. Just a few housekeeping items before we begin. Please ensure your phone is muted and ensure you click full screen in the upper right-hand corner in order to capture the optimal screen resolution for today's presentation. After today's presentation, we will have a Q&A session with Dr. Hoy. We ask that you submit your questions through the chat option. Additionally, today's webinar will be recorded and will be available online. Today's speaker is Dr. Eric Hoy. Dr. Hoy earned his Ph.D. degree in pathology from the University of Illinois College of Medicine in Chicago. He has been involved in laboratory medicine and pathology for over 40 years. Dr. Hoy recently retired from the University of Texas Southwestern Medical Center at Dallas, where he taught basic immunology, clinical immunology, and molecular biology in the Department of Medical Laboratory Sciences. Dr. Hoy does research directed towards finding better tests for the clinical laboratory to use in the diagnosis of diseases. Dr. Hoy's major interest in the field of clinical immunology is autoimmune diseases. Dr. Hoy has also acted as a medical consultant for the PAN Support Network for many, many years, and also has participated as a speaker at many of our Vasculitis Foundation International Symposia. I'd like to welcome Dr. Hoy to today's webinar.
Thank you, Joyce. I think my screen is up there now, and everybody can see it.
We can.
I am Eric Hoy, as Joyce said, and I recently retired 2 years ago from the University of Texas, and I have been involved in laboratory medicine for a long, long time, and I'm very enthused about laboratory medicine, so I want to help everybody try to understand what your lab tests mean, why the doctors are ordering them, and so forth today. So we'll move on here to our first slide. The laboratory process begins with a sample, and that sample then goes to this big black box called the lab, and magically a result pops out the other end. And this is about all most people know about the lab, is it's this big black box, and somehow a blood sample or a urine sample or some tissue sample goes in and a result comes out. So what I want to do today is kind of demystify the black box and talk about what happens during that process and how your sample is handled and how the results are determined. So I get a question frequently, what can we test? What can we send into the laboratory? And our rule is if we can take it out of you or off of you, we can test it. We go through a lot of different samples, blood, urine, other body fluids, swabs of skin areas or wound areas are frequently swabbed. Biopsies of tissue can be sent to the lab. And so we say that everything from the hair on your head to your toenails and everything in between can be tested in the lab. What don't we test? We don't test food. I've had patients, I just recently had a patient, or an individual, he wasn't a patient, but he called and said that he had gotten food poisoning and he thought it was from a burrito that he had eaten. Found a piece of the burrito on the floor of his car and he wondered if he could bring it in the lab and have us test it for food poisoning. Well, we can't do that for a number of reasons. We're not equipped to do testing on food products, first of all. Secondly, after it's been laying on the floor of the car for a few days, it isn't representative of what he actually ate. It would be much better if he could bring in a sample from his own self, if he's vomiting some vomit or whatever, that we could test and see if there are any organisms in there. There are food testing labs, and in most states the public health lab will test food if it's suspected of being contaminated with microorganisms. Similarly, we don't test cosmetics. I get frequent calls from people that they've broken out and they think it's because of a cosmetic they're using, and can we test it? Again, we're not equipped for that. the public health labs can handle that. Environmental samples. I've had people bring in samples of water from a standing puddle behind their house, and they want to know what organisms are living in there. Well, we're not equipped to do that. There are labs that will do environmental sampling. We're also not equipped or licensed to do forensic samples. So we can't test the DNA that you found on the pop bottle from your daughter's boyfriend and check out his background or something like that. And I've had requests like that. We're not set up for that. And again, there are specialized forensic labs. We will not test something that you found in the back of your refrigerator or in a bathroom drain or growing on the floor of your garage, all of which are requests that we have had. But again, we're not designed to do that. We're designed to handle clinical samples taken out of or off of a human being. Some interesting facts about the lab. There are over 9 billion laboratory tests being performed each year in the United States. In the year 2015, these statistics came out of 9.25 billion laboratory tests. And the rate of laboratory testing is increasing at right now about 17% per year. So as our population ages and as we baby boomers now are retiring and getting older, we're having more aches and pains and more diseases, and so more laboratory testing is being done. Laboratory tests are extremely important in the overall picture of medicine. It's been estimated that between 70 and 80% of clinical decisions are based on laboratory results. So in making the diagnosis, determining the treatment, monitoring the treatment, all of that depends on laboratory results. These statistics came from the Clinical Laboratory Standards Institute in Pennsylvania. So, welcome to the clinical laboratory. We had this sign in one lab that I worked in. We had this hanging where the physicians could see it when they came in to bother us. And we said we can provide results that are fast, accurate, and inexpensive. And you can choose any two from the list. We can't do all three, unfortunately. So if you want it fast and inexpensive, it's probably not going to be very accurate. If you want it accurate and fast, it's going to be very, very expensive. And so we have to weigh these different factors as we choose the test we're going to do in our lab, as we choose the method we're going to use, and how fast we need to get the results back to the clinician and back to the patient. Another one of our favorite sayings is they may be body fluids to you, but they're bread and butter to the lab. The vast majority of samples that we test in the clinical lab are blood and urine samples. We do get other samples, but blood and urine are the major samples that we get and that are tested in that 9.25 billion laboratory tests that are being done each year. Blood tests begin with the process of phlebotomy. And I think everybody's probably had blood drawn at one point or another. The individual drawing the blood, this gentleman on the right in the blue coat here, his job title is phlebotomist. And that's all he does in most big labs is draw blood from patients. He's trained in this, usually a 2-year associate degree is needed to qualify as a phlebotomist. And within that training, there's a lot of practical work. These folks are very highly skilled in their ability to find veins, draw blood, get good samples for us to work with in the clinical lab. They don't actually do the testing in the clinical lab. They're not nurses. I've often been told, well, the nurse drew my blood. Unlikely. Maybe in a doctor's office, the nurse may be drawing blood, but in a hospital setting, in a clinical lab setting, we have trained phlebotomists to do the blood drawing. High volume tests like blood glucose and cholesterol, where we're doing hundreds of them a day in a large university laboratory, are run on automated analyzers. And these are very sophisticated machines. They're computerized. They usually have an onboard computer, and then they communicate with the major laboratory mainframe computer. The individuals that run this are individuals different from the phlebotomists. These are the clinical laboratory scientists. These are the unsung heroes of laboratory medicine. These people all have at least a bachelor's degree. Many of them have master's degrees in a clinical science, chemistry, phlebotomy, or chemistry or hematology or immunology, microbiology, and they have specialized training in clinical laboratory medicine. And so all of them have spent at least 4 years in school, many of them years beyond that, to qualify to work on your samples in the clinical laboratory. You generally don't see these folks. We're tucked away in the lab, is usually off in the basement someplace, often in another building from the main clinical building. And so, so you don't cross paths with the medical laboratory scientists, but they're very important in the overall picture. So here we see a medical laboratory scientist. She's loading a rack of samples into the analyzer, and then the analyzer will automatically process those samples and will determine the levels of different substances, glucose or cholesterol or whatever we're testing for. Another view of a large automated analyzer is here. This technologist is loading things in. On top we have this big lid that comes down on top of it while it's running, and the clinical laboratory scientist then can go do other testing while the instrument is running. On the left side of the picture here you see these large tanks. These are water purification tanks. We use a lot of water in the clinical laboratory, and it has to be very pure. We even have standards for how clean the water has to be, because we want to make sure that when we're measuring your blood sample, we're not also measuring the water that we use to dilute that sample. So if we're running calcium, we have to have absolutely calcium-free water to determine what your blood calcium level is accurately. Automated analyzers are very popular in clinical labs. They can handle a large volume of samples in a relatively short period of time. They're used for most of our routine tests. They usually give us rapid turnaround time. So if we want a blood glucose, for instance, on a patient within an hour or two after the blood sample is obtained, we can have that back to the physician in that period of time. They do require monitoring. The clinical laboratory scientists have to maintain the instruments properly and monitor them and do quality control checks on them. About 20% of our work is just in quality control testing. But they're relatively labor-free. They're fairly expensive to purchase. These run in the neighborhood of $100,000 to $500,000, depending on what they do and how sophisticated they are and how fast they run and lots of different factors. But once a lab has made that initial investment, the labor savings will help offset that expense of the purchase. Some of them are expensive to run. The companies that build these instruments want you to use their reagents and their tests on them, and so the cost of those tests can sometimes be higher than using a different methodology. So methods will vary from one lab to another depending on what instruments they have and how much money they have to invest in their instruments. Many lab tests are still done manually. Here we see the clinical laboratory scientist manually putting some drops into some test tubes here in a blood bank test. She's doing blood grouping and typing to determine the patient's blood group and type in a manual format. Here the medical laboratory scientist is pipetting using this device to remove a small amount, very small amount, less than a drop in some cases, of this particular reagent to put into a test. Here we see that same pipette going into the tube, and the general rule with manual testing is that one test tube represents one assay. So if we're doing a blood glucose, we have one test tube for that. On the same patient, if we're doing cholesterol, we'll have another test tube for that test. So we have multiple tubes sometimes for patients. So if we have multiple patients all running the same test, or a single patient running multiple tests will have multiple tubes. And here we see the clinical lab scientist. She's pipetting using this device into multiple tubes in this rack. And this is something that we want to keep this sterile. So she's working inside of this hood. There's an air curtain running inside the hood, and she's outside. We have this little sneeze glass in between to prevent her from contaminating the sterile fluids she's working with inside the hood. In microbiology, we work with microorganisms, and we work with cultures. Very frequently, these come to us on a swab. It could be a simple throat swab looking for strep throat in a child. It could be a wound swab from a patient who's had surgery and the wound is now infected, or a traumatic wound that has become infected. We get a variety of samples in the microbiology lab. And they're first plated on a Petri dish containing a rich agar mixture here. This agar has blood in it, so it looks bright red, and we very cleverly call it blood agar. And it's a general culture medium that we will use to grow the initial bacteria, and then we'll identify the bacteria using various biochemical tests that change color. And this medical scientist is looking at some of those tests, looking at the color changes in the tubes to determine what this bacteria is and what infection might be happening in the patient. We'll isolate the bacteria from the patient, then we can do antibiotic susceptibility testing, and that's shown on this Petri dish here. We've plated the bacteria, and this happens to be a green pigmented bacterium, so we see this green color. We plated that bacterium on the agar, and then we drop these little discs of filter paper on the agar in a pattern here, and each one of these is impregnated with a different antibiotic. We incubate this overnight, and then we look and we can see zones of inhibition. We can see where the green bacteria are growing, but we can also see where they're inhibited around some of the discs. Those antibiotics are effective in killing that bacteria. And so, and then we have some where the bacteria have grown right up to the disc. Those antibiotics are not effective in killing the bacteria. So we can determine from this the drug or drugs that the physician should be using to treat this particular infection. And we can assist the physician in selecting the right antibiotic for the infection that we're dealing with. So this is what goes on in the microbiology section of the lab. In some tests, we do microscopic analysis. In this case, the clinical lab scientist is looking through the microscope. She's looking at a blood smear. This is what a blood smear looks like under the microscope. We see red blood cells, very abundant red blood cells, and then these larger cells with the purple nuclei in them are the white blood cells. And what she's doing as she looks through here is checking these white blood cells, enumerating the different types and the different shapes and colors of these, tell us what type of cell it is, and that will give us an indication whether the patient has a normal blood smear or an abnormality of some kind in the blood. These small pink areas here between the red blood cells are the platelets. And so just looking at a blood smear, we can get an estimate of whether the platelet count is normal, and blood clotting should be normal if the platelet count is normal and all the other factors are present. So with a simple microscopic analysis, a trained clinical lab scientist can tell a lot just looking at a drop of blood on the microscope slide. Some slides, some tests we use just the color interpretation, a visual interpretation. This is a basic, what we call a dipstick urinalysis. We have this dipstick, a little plastic stick, and it has pads of filter paper on the stick. In this case, we have 9 different pads on the stick, and each one is impregnated with different reagents, which will react with substances in the urine. So we dip the stick into the urine and then observe for color change in the pads. And depending on what color each pad turns, We have a chart here on the bottle of these sticks, and we can compare and determine, is there blood in the urine, is there protein in the urine, what is the acidity level of the urine, the pH, other substances, bile in the urine, and other things we can test for. Some of you may be doing this at home. This is a very simple test. You can buy the dipsticks at the pharmacy. If they don't have them in stock, they'll order them for you. And for many of our patients, particularly lupus patients who are prone to developing chronic kidney disease, chronic kidney inflammation, we'll have them check their urine periodically, once a week or so, with a dipstick that looks for blood and protein, because these are early indicators that there's inflammation in the kidney and that we may be seeing some kidney damage. If we catch it early enough, we can treat the patient for it and eliminate or minimize the amount of kidney damage that has occurred. So even simple visual tests like this are very important in determining the overall health of the patient. Now, in the world of microscopy, looking through the microscope, we do a lot of microscopic work in microbiology and immunology and hematology, where we're looking at cells, we're looking at structures. And in the immunology lab, we use a technique called fluorescent microscopy, where we use a fluorescent dye to dye the cells. And you can see them on the computer monitor here with this bright green fluorescent dye that dyes the cells, and we can look at structures in the cells. We can look for antibodies that bind to the cells. Very versatile technique for the clinical immunology lab. But it is very labor intensive, and it takes a lot of time, and traditionally it's done in a dark room or closet someplace where the microscope is set up so that we can see the fluorescent reactions. Several years ago, our lab started working on an automated version of the fluorescent microscope. And what we see here is the current version of that, which is undergoing FDA scrutiny right now, and we expect to get FDA approval within the next 30 days to sell this instrument in the United States. It's being sold in Europe, it's being sold in Australia right now, and it's becoming a very popular laboratory instrument for doing automated microscopy, automated fluorescent microscopy. So this, again, frees up the clinical lab scientists to do other tasks while the instrument is capturing the images, and then it displays them, and the clinical laboratory scientists can look at them on a monitor instead of through the microscope, and can make the diagnosis and assist the clinician in that fashion. What we see here on the monitor is an ANA test, anti-nuclear antibody test, which doesn't really apply to most vasculitis patients. It's a test we use often for lupus and Sjogren's syndrome, other autoimmune diseases. But we can do the ANCA test. The ANCA test is done by fluorescent microscopy as well. And here we see the two different patterns of positive ANCA tests by fluorescent microscopy. Many of you have probably had ANCA tests run in the past. You may have them done on a periodic basis. So what we see here in the lower right is the p-ANCA pattern. Perinuclear is where the P comes from, because the nucleus of the cell is showing the fluorescent reaction. In the upper left, we see the c-ANCA pattern, or cytoplasmic ANCA, where we have little granules in the cytoplasm of the cells that are showing the staining. And so this can be used on the automated microscope. The Image Navigator is the brand name of it. And this will speed up, and it will also increase the accuracy of ANCA testing. ANCA tests vary quite a bit from one lab to another. They're run with human cells on the microscope slide. The quality of these cells can vary from one preparation to another. The ability to interpret and detect these patterns can vary from one individual to another within the laboratory. And so we do a lot of training and a lot of proficiency testing before we'll allow one of our clinical lab scientists to do the ANCA tests. But even at that, I get complaints or questions from patients who say, well, my ANCA was done 6 months ago and it was strongly positive, and today it came back negative. Well, what's going on? Well, a number of things could be going on. It could be that your clinical condition is improving, that the doctor's treating you, and that the antibodies that cause the ANCA test are disappearing. That's a very good sign. But it could also be variation. Was it sent to 2 different labs? Has a lab changed their method in the 6 months between the 2 tests? A lot of different questions need to be addressed to look at the quality of tests and comparing one test to another or one lab to another. We'll talk about that a little bit more in just a minute. So I want to cover some frequently asked questions in anticipation of things that you might be asking, and then we'll open it up to a question and answer, and we'll cover an actual lab report and look at some of the things to look for on a lab report, and then we'll open it up to questions and answers. One question I frequently get is that my doctor ordered 2 tests on me, but when I came in they drew 3 tubes of blood. Why did you draw the extra blood? We've been accused of doing research on people and using their blood for blood bank and all that. None of that is true. We can't do research on you without telling you about it. For blood bank, we need very specialized ways of collecting the blood, so we're not going to collect it in little tubes. The reason we collect multiple tubes in some cases is shown here. We have a lot of different color caps on these tubes, and that isn't just for show. Each one of these is used for a different purpose in the lab. The blue cap tube is used for coagulation tests. The lavender cap tube is used for hematology tests. The red cap and green cap and orange cap and gray cap and black cap tubes are all used in chemistry, but for different tests. And so even though your doctor ordered 2 tests, one test may encompass a number of different assays, and we may need both a red top tube and a green top tube to do all those assays that are part of that profile that he's ordered. In some cases, we need both blood with anticoagulant from a purple top tube and clotted blood from a red cap tube for the same test to do a comparison of clotted and unclotted blood. So we'll draw 2 tubes in that case. So don't panic if they're drawing more than 1 tube of blood. There is a reason for it, and we're not picking on you, and we're not trying to steal your blood. Another question I often get is that sometimes my lab results are ready the next day, but other times it takes 2 weeks or longer to get the lab results. And we refer to this as turnaround time in the lab. How fast can we turn it around from the time we receive the sample until we get that result into the clinician's hand is our turnaround time. And that depends largely on the test that was ordered and whether our lab is performing that testing or whether we have to send it to a reference lab. Very high volume tests like blood glucose are done in every lab, and they're done each day, often multiple times during the day. In a very large lab, it may be an almost continuous process where they're continuously running blood glucose tests. So as the samples come in, they're placed on the analyzer, they're analyzed, the results are confirmed, and the results go out oftentimes within an hour or 2 after that sample comes in. And so those will be very rapid turnaround times. Your clinician will have those results the next day. Lower volume tests, and in many labs ANCA qualifies in this regard, or ANA testing, may be only done once or twice a week, depending on how many tests the lab gets and how frequently the clinicians want the results back. So these may be batched once or twice a week, and so it may take longer to get the results back. So every test has a different turnaround time depending on the lab and the test itself and whether it's done in that lab. Another question I get is, why are lab tests important? Why can't my doctor just figure out what's wrong with me when she examines me? I'm in her office, she can poke me and look down my throat and do all the things that the doctors do in the office. Why do they need the lab tests? Well, we use the lab tests along with the symptoms and physical exam. And the results will assist the doctor in making the diagnosis in most cases. Remember, as I said earlier, 70 to 80% of clinical decisions are based on lab results. So you may have a symptom. You may have muscle aches, for instance. Many people come in with muscle aches. Well, there's a lot of things that can cause muscle aches or joint pain. And so we'll run some lab tests to either rule out certain causes of the joint pain or to help us confirm what's causing the pain. And so the combination of symptoms, physical exam, and lab results are all needed together. This is why it's difficult to sometimes interpret a lab result in isolation. I get a person who calls me and says, I just got my lab test back and it showed protein in my urine. What does this mean? Well, by itself, it doesn't mean very much at all. We need to look at the total picture to make that determination. Another test that we frequently get is that the patient is told that they can't eat anything or drink anything after 10 p.m. the night before they come in for their blood draw. And they say, why is this? I get very hungry. I normally eat breakfast at 6 in the morning, and I need to, and I'm hungry by the time I get to the lab. Why can't I have something to eat? Well, with some tests, we want a fasting sample. This helps us establish a baseline for that particular patient of what their level of glucose is, for instance, when they're fasting, when they haven't had any carbohydrates to eat for the past 8 hours or so. And in many cases, we're interested in the change in values from one visit to the next rather than a single test. A single lab test can sometimes give us an indication of disease, but it isn't always definitive. And so sometimes we'll run a series of tests a week apart or a month apart just to see how much they vary from one time to another. And so we want any interference from food or drink to be eliminated from that analysis, and so we'll ask for fasting samples on all those occasions. And now the big question, the one that I get frequently and is very difficult to answer because, as I said, I may not be seeing the patient, I may not be doing the physical exam, and I don't know what the symptoms are, I don't know what treatments the patient is getting, but our lab did the work, the patient looked at the lab work, and I get a question like this, that I got my lab work back, the BUN, or blood urea nitrogen, that stands for, is elevated, it's flagged as being high. I looked online and it said this is a kidney function test. Are my kidneys failing? Well, first mistake that you made was you looked online. You'll find a lot of information online that is very good and a lot of information that is very bad. You need to talk to your doctor about this. Looking online, you'll find things that will frighten you or may minimize the importance of the lab test. The simple answer to are my kidneys failing is probably not, but we need to know a lot more before we can make that determination. Let's look at an actual series of lab tests on a patient. This is a patient, and we've blacked out her name for privacy reasons here, but she was a 72-year-old female, and when she first came, these are outpatient results. So she was an outpatient, she came into the clinic, and her diagnosis at that time was that she had elevated thyroid hormones, an elevated cholesterol, and dry skin. And so chemistry tests were run in the automated chemistry lab using one of those big automated instruments. A whole battery of tests was run, and all of them were within what we call the reference range. The reference range is based on a large population of individuals, and it may vary depending on gender or age or race. All of those can affect reference ranges. And so these are the reference ranges in this laboratory for a 72-year-old female. For each of these tests, and it's hard to see, we'll enlarge it here on this next slide to show all of these numbers, but the important thing is that all of these are within the reference range. They're all normal values, except for the cholesterol. And it's flagged as being high. The little H here next to it means that it's out of the reference range and it's high. And a little A footnote here means that it's a very high level. 250, 240 is considered a high cholesterol level. So at 250, it's a very high cholesterol level. So that's the only thing that we're seeing in this patient that is abnormal. And we see that frequently in patients in their late 60s and 70s. We start running higher cholesterol levels, and we have a number of drugs that can help control those high cholesterol levels. So this is not very concerning. This was done on May 8th in 1998, and the values I want to concentrate on are the BUN and creatinine values here. The BUN is 18, which is within the reference range here, 8 to 20, and the creatinine is 0.7, which is right at the bottom of the reference range, but still considered within normal limits. So we look at our reference ranges and we say that these are normal, but we have to know what the reference range for that lab is, because in another lab we see these results, and here we see the reference range for BUN is 6 to 23, or back here it's 8 to 20. And the reference range here is 0.7 to 1.4. Here it's 0.67 to 1.17. And so if I have a BUN value, customer calls me, a patient calls and says, I have a BUN of 21. What does that mean? Well, in this lab, it means it's slightly elevated. In this lab, it means it's within normal reference range. So it varies from the lab. So what are the differences? Gender is one. Believe it or not, men and women are different. And so we see different normal reference ranges for many laboratory results. Age can cause variation, particularly in pediatric patients. We have pediatric reference ranges that are entirely different from adult reference ranges. Race can affect certain values, and particularly kidney function values may vary between African Americans and Caucasian Americans. And so we need to know all of these as part of our analysis of what these numbers mean. And it's also very important what the laboratory method is and what kind of analyzer they're using, what kind of reagent they're using to run each of these tests. Shortly after the patient had the chemistry test done, she also had a hematology test done, a complete blood count, and these are all the different things that are covered in a complete blood count. And again, everything is within reference range here. Very important to look at the red blood cell count, the hemoglobin, and the hematocrit. These are indicators of anemia. And in this patient, she has very nice values for a woman of 72 years of age. They're all within the normal reference range, no borderline values. They're all pretty much right down the middle of the reference ranges. So this is on June 1st. Now, in fact, the doctor was so enthused about this that the clinician wrote on here, call the patient, blood tests are all okay. And the nurse has made a notation over here that on the 3rd of June, she called the patient with normal blood results. Now, that's ignoring this one little result here in the special testing area called the sedimentation rate, or SED rate. The reference range for this is 0 to 30 for a 72-year-old female, and hers is running 43. So it's high, and it was flagged as high, but it's a very non-specific test. It indicates there may be some inflammation going on somewhere, but it doesn't really tell you what disease state there is or what problem the patient may have. So the doctor has looked at this, but is pretty much dismissing it because everything else is normal. Well, if we move on here, now here in August of that same year, late August, so we're looking at almost 3 months later, the patient has been admitted to the hospital now, And her values, particularly for the BUN and creatinine, are very different on this occasion. They're up to 25 for the BUN, well above the upper limit of the reference range, and 2.8 for the creatinine, which is twice the upper limit of normal for the creatinine. So they're flagged as high, and then they also have the little hash mark in front of them, indicating that there's a significant change from the previous sample. We call this a delta. Delta is a Greek letter that's used in math for a change from one value to another. And if we look at the delta value, this patient also had samples. I don't have that lab report, but she had a sample taken on the 26th, the day before. This sample was taken on the 27th at 4 o'clock in the morning. This sample was taken on the 26th at 4:20. So within 24 hours, the BUN had been 44. It's down to 25, but it's still elevated. The creatinine had been 4.1. It's down to 2.8, but still markedly elevated. So the day before they had run these tests and had realized this patient now has acute renal failure. These values are very abnormal and indicate a loss of kidney function. So they've started some therapy on her, and I'm not sure what therapy was used, but it may have been dialysis, it may have been drug therapy of some kind, and it is reducing her BUN and creatinine levels, but they're still highly abnormal. At the same time, a sample was collected for the complete blood count, and the patient shows marked anemia now. All of these, the red blood cell count, the hemoglobin, the hematocrit, are all below the reference range. They're low values, and so this shows anemia as well as the kidney failure. So this patient in a very short period of time has gone to from being basically healthy, normal laboratory results to acute renal failure and anemia. So our synopsis of this case is that this is a 72-year-old woman. She was in basically good health in May or June. She was complaining of dry skin and she had elevated cholesterol, but nothing very serious. But by August, she's suffering from acute renal failure. This was supported by the laboratory results, and in spite of aggressive treatment, this patient died shortly after that. Her final diagnosis was polyarteritis nodosa, a form of vasculitis. And so some forms of vasculitis can have very rapid onset. She had probably had the vasculitis, and the early indicator of that was that elevated sedimentation rate, that there was some inflammation, but it wasn't causing her severe problems until she had the acute problems, and she had acute abdominal pain, came in for that, and then was found to have the kidney failure and the anemia, which ultimately led to her death from polyarteritis nodosa. So some forms of vasculitis are slow and chronic. Other forms of vasculitis can be quite aggressive. And so we have to be able to identify and diagnose those forms and let the clinician know as quickly as possible. So let's conclude and then have a few minutes for questions and answers. The laboratory testing is vital to a quick and proper diagnosis. With certain lab tests, we want to get the results as fast as we possibly can and get them back in the hands of the clinician so that a rapid diagnosis can be made. Laboratory tests can be simple, little dipstick urine tests, or very complex fluorescent microscopy tests that require a very highly skilled reader to look at those cells, determine what the pattern staining is, what's happening inside the cells. And so the interpretation of laboratory tests requires knowledge of the laboratory method, first of all, and then also the patient's physical status, their history, their treatments, age, gender, and race, all of which can affect the laboratory results and our interpretation of those laboratory results. So if you call me to ask about your elevated lab result or BUN result, be prepared for a lot of questions back from me because I don't know your physical status. I don't know what drugs you're taking. I don't know what your other lab tests were. And it's very important that I know all of the other lab tests to make a determination of the one abnormality, because if there's other abnormalities, either high or low, that can affect the decision on the one test that you're concerned about. The best resource for interpretation of your lab results is the doctor who ordered them. Call the doctor back. Questions to ask are, why did you order the test? What do you expect to find? And will my treatment change if the test is abnormal? Or conversely, will my treatment change if the test is normal? Will you be able to take me off of the drug or taper me off of the drug if this test is normal? And these questions will often elicit the best answers you can get from your attending physician. So some good resources online are the Vasculitis Foundation website is excellent for information on vasculitis. For lab tests in general, this website, labtestsonline.org, is a service of the American Association of Clinical Chemistry, and many clinical lab scientists are members of that organization, and they've put together this online resource that explains virtually every lab test that we do in the clinical lab. And we'll talk about the preparation for that lab test, how the test is done, and some interpretation on it. And then the Mayo Medical Laboratories website also has excellent information and is a good resource. Other resources may give you information about lab tests, but I don't trust them as much as I trust these three particular resources. So that brings us to my slide thanking everyone at the Vasculitis Foundation, particularly Joyce Coleman and Ed Becker, who set up this webinar and made it possible for me to talk to you folks today. I want to thank the patients who allowed me to use their lab results in the seminar. We are very jealous of the confidentiality of the lab results. We won't share them with anyone without your permission, other than the doctor that orders them and the patient. And I want to thank all of you for attending and sitting through the webinar. And I think now we can open it up to questions.
Great. Thank you so much, Dr. Hoy. Thank you so much. So I'm going to turn the moderating over to Kaylin Young, who is our network manager of the VPPRN, and Ed Becker, who is our marketing and communications director and also the leader of the PAN support network. Kaylin and Ed, do you have some questions from the audience?
We sure do. So please, just a reminder, if you have additional questions, you can submit them using your navigation bar. It should be on the right side of your screen. There should be a little box for questions. You can submit them there. So one of the questions we received during the webinar was, how soon after you're off prednisone should your blood be taken or tested?
Depends on what you're looking for. In the blood sample. If you're looking to see if the adrenal function is returning, we should probably wait a couple of weeks after withdrawing the prednisone to look for improvement of the adrenal function or recovery of the adrenal glands. If you're looking at something like calcium level to see if osteoporosis is a problem, that sample could be taken immediately the day after you stop taking prednisone. We might get a baseline calcium and then look at it again in a month or 3 months and see if the calcium levels are going up. Again, it depends on exactly what the clinician is looking for. So I would ask the question, why are you ordering the test? What do you expect to find from this? And are you going to put me back on prednisone if something is abnormal?
Great, thank you. Ed, did you have additional questions that were submitted?
Yeah, I do have a few questions, excuse me, that came in. But Dr. Eric, I'd like to actually ask a question related to the lab report that you were showing. And the fact is, I actually know the person pretty well whose report that was. And what was curious to me was that in May, the report looked, I guess, from what I heard from you, was fairly unremarkable. But the patient had actually begun showing some of the early symptoms back in January, February, and in fact was had complete renal failure a month after those May tests were done, and that's when the diagnosis was made. So I guess it's as much of a comment that it's curious that those labs didn't reflect anything too dramatic in terms of inflammation when the patient was actually, with the disease.
Yes, and this is one of the frustrating things about dealing with vasculitis, is that there aren't a lot of really good laboratory tests. The ANCA test is good for GPA and eGPA and a few other vasculitis conditions, the so-called ANCA-associated vasculitides. But many of them, polyarteritis nodosa, there are no specific lab tests that will tell you the patient has PAN other than a biopsy and looking at the tissue in the histopathology lab. And so, and that's an invasive procedure, and you have to know where to biopsy, and there's a lot of factors involved there, so we don't just randomly biopsy people. But there isn't a good blood test or urine test for most forms of vasculitis where we can simply run that. And that's one of our goals. That's some of the research we're doing. Some of the things we hope that we'll be able to adapt more tests to the automated microscope system to look for different biomarkers in the blood and in body fluids in order to identify these diseases early on and start aggressive therapy, because it does require very aggressive therapy early in the disease to prevent the tissue damage that leads to kidney failure and death in many of these patients.
So yeah, and to be fair to the doctor who had seen that report, nothing would have jumped out at them necessarily at that point as to what was the underlying condition.
No, and as I noted, both the doctor and the nurse wrote on there, reported normal lab results. This looks great to me. The labs look normal. So even though the patient had symptoms, the lab results actually in this case were kind of a red herring, because the doctor looks at him and says, well, I don't find anything wrong here, and the symptoms may be vague. It may be pain, abdominal pain, or joint pain, and so it's difficult to pin down exactly why the patient is having this pain, and none of the lab tests are showing any abnormalities.
Mm-hmm. Thank you. One question came in. My doctor's ordering a punch biopsy. Can you tell me a little bit about this test and what to expect?
The punch biopsy gets its name because it's a little cylindrical instrument that punches out a small piece of skin and some underlying dermal tissue underneath. And what they're looking for is inflammation in the skin and the blood vessels there. There's many cutaneous manifestations of the various vasculitides, and very often this is a simple way to do a biopsy without having to do a nerve biopsy or an abdominal biopsy or some more invasive procedure. And so they're going to use this little cylindrical punch. They'll deaden the area with some local anesthetic, and then just punch out a small piece of the tissue there, and it will be submitted to the histopathology lab. It will be processed to look for various markers in there, and will be examined by a pathologist, or in a large medical center, a specialized pathologist called the dermatopathologist, who looks exclusively at skin samples to determine the whether it's normal tissue or not. Now, some punch biopsies, some clinicians, dermatologists particularly, like to take what's called a triple biopsy. And so they'll take a biopsy within the area of inflammation. If there is an area of inflammation or a nodule or something that has raised their suspicion on the skin, they'll biopsy right within the center of that. And then they'll also get some at the margin, because sometimes that's where the active inflammation is, right at the margin of that lesion, whatever it might be. And then they'll take a third a punch slightly outside of that area to get normal skin to compare, so that the pathologist or dermatopathologist now has 3 different samples to compare, where we have active inflammation we have normal tissue, and then we have the center of the lesion where the damage is the worst. And so here again, they're only doing one biopsy, but they may take multiple punches of the tissue. But it's a completely painless procedure. You may require a Band-Aid on there for a day or two, but it'll heal up nicely.
Okay, thank you. Two other questions here. What do you see on the horizon in terms of technology and advancement of diagnostics? Like what's on your wish list that you hope to see in the next 5 to 10 years?
One of the things that there's a lot of research in a lot of different places, and I know a lot of the researchers, we share data because we learn a lot more that way. We're looking at what are known as biomarkers, proteins or antibodies in the blood or in a body fluid that are unique to a given disease state. This is how ANCA was discovered back in the 1980s. The researchers looking at patients with kidney failure due to vasculitis found that the majority of these patients had these antibodies that reacted with the nuclei of human cells called anti-neutrophil cytoplasmic antibodies, and the ANCA test was born. So we're looking at a variety of different proteins and antibodies that may be present in patients. One of the problems with doing that kind of research is that these are rare diseases. So we need patients to participate. And I know you have put out a number of messages. The Vasculitis Foundation has information about participating in some of these research studies. Some of them are as simple as just giving a blood sample. Some are much more extensive than that, where they're going to follow the patient over a period of time. But there are a number of opportunities for patients with vasculitis to participate in studies that will then give us the information and give us the better laboratory tests down the road. I hope that within the next 5 to 10 years, we have a good general test for vasculitis. I don't know that we'll find that because it is a rare disease and difficult to work with.
Okay, thank you. Last question. What are the markers, you alluded to this earlier in your talk, but what are the markers that are most important for the vasculitis patient? What are the readings, the BUN and the ESR? What should they be zeroing in on that lab report?
The ESR, the erythrocyte sedimentation rate, and the CRP are two tests of general inflammation. And so if there's any inflammatory process, and this could be an infection, it could be vasculitis, it could be a wide variety of things that cause inflammation. But if there's any inflammation, those will be elevated. And so that's kind of a good screening test. If those aren't elevated, there's no inflammation. You still may have a chronic condition, but it's less likely to be causing tissue damage. If there's kidney involvement, we're going to see elevation of the BUN and creatinine will be early indicators. Protein in the urine is an early indicator of kidney inflammation. So again, a simple little dipstick test. If you know you have vasculitis and you're at risk of kidney problems, it's probably worth going down to your local pharmacy and seeing if they have the dipsticks. You can get them for just protein and blood. You don't have to do all 9 tests that are done on the big stick. And just test for protein and blood because those are good indicators of early kidney inflammation. But then when the lab tests are run, the BUN and creatinine are good kidney tests. If there's liver involvement, there's liver-specific tests. AST, ALT, bilirubin are all tests of liver function. Lung function we can generally tell because you become short of breath very easily. And a simple chest x-ray may show lung changes. Sinuses in patients with GPA in particular, and with Churg-Strauss eGPA, we may see sinus involvement and sinus inflammation. And so tests of body fluids, if we've gotten sinus drainage fluid in the lab, to look for an infectious cause. If there's no infectious cause, it may be inflammation due to vasculitis. So as I said, there's no one test that we can jump on and say this is the test for vasculitis or for this form of vasculitis. but we have to look at a whole picture of symptoms and clinical findings and laboratory results as well.
Okay, thank you very much. Kaylin, back to you.
Great, thank you. So we are almost at the top of the hour, but we have just two more quick questions, if you wouldn't mind. So one was about abbreviations on some of the test results. So there was a question submitted that abbreviations on my test include MCH and LDH. What do these stand for, and what do the readings mean?
MCH is a part of the blood count, the complete blood count, and that's the mean corpuscular hemoglobin. So we take a look at millions of red blood cells, corpuscles they used to be called, and we measure the amount of hemoglobin in each one, and then take the average value, which is called the mean. And this is all done by an automated instrument in a matter of seconds. We don't have to sit there and look at each cell and figure it out. But and that's an indication of, you may have a normal red blood cell count, but if the amount of hemoglobin in each cell isn't adequate, you'll still be anemic. And so we look at a number of different parameters in determining if there's anemia there. A low MCH all by itself probably doesn't mean very much. Again, we have to look at the whole complete blood count to determine, is this patient anemic or is there another problem? The other one was LDH, was it?
Yes.
Okay, that's lactate dehydrogenase, an enzyme. That's one of the chemistry parameters that we measure in the automated chemistry profile or the metabolic profile, and that is a liver function test basically. And if it's elevated, there may be problems in the liver, but there are a number again of liver function tests: AST, ALT, bilirubin, LDH, alkaline phosphatase are all measurements of what's going on in the liver. And so we have to look at that whole profile and not just one test in isolation. So a single elevated LDH may or may not be significant. Again, we have to look at the whole picture and why did the doctor order the test in the first place. But the abbreviations can be very confusing, and it is like learning a foreign language for our medical lab scientists when they first start learning in the lab, learning all these abbreviations and the jargon that we use and so forth. But it is the one means of communication for us and the clinicians. Without using all these big fancy words, we can rattle off these quick little three-letter abbreviations and know what the other person is talking about. As far as for you, you can probably look those up on lab tests online. If you type in LDH, it'll probably give you lactate dehydrogenase, and same thing with MCH. So that's a very good resource for interpreting your lab results.
Great, thank you so much. And then the last question was just about CAT scans and MRIs and the interpretation. Do you have perhaps maybe a resource that our participants could look at that might help answer those questions?
Not really. That's not outside of the lab. That's radiology or nuclear medicine does those tests. And so they're not really laboratory tests. There may be radiology websites or just going to Google and type in MRI interpretation and see what comes up. I haven't looked for a good one. I haven't had a necessity to look for interpretation of MRIs, but I can do that and get back to Ed with it, and maybe he can post something on the Facebook site or on the Vasculitis Foundation page.
That would be wonderful. Thank you so much. Joyce?
Great. Thank you, Kaylin and Ed, for coordinating the questions. And again, Dr. Hoy, thank you so much for your presentation today. We always appreciate you sharing your knowledge and expertise. We'll do a quick wrap up since we're a little over time. I wanted to thank all of you for joining us for today's webinar, and I wanted to invite you to join us for one of our upcoming webinars. On April 27th, Dr. Carolyn Thorpe from the University of Pittsburgh will be providing an update on her VF-funded study, The Impact of Healthcare care utilization in informal caregiving for primary systemic vasculitis. So that's on April 27th. And then on May 5th, Dr. Carol Langford from the Cleveland Clinic Center for Vasculitis Care and Research, she will be joining us for a retrospective on the past 30 years of advances in vasculitis and research. The VF, we are celebrating our 30th year anniversary this year, and so Dr. Langford has been one of our long-time medical consultants, so we're looking forward to her presentation. We also hope that all of you will join us in Vasculitis Awareness Month activities during the month of May. It's our time of year to raise awareness of vasculitis and the VF in the general public with our friends through social media, through contacting your local media, etc. We will have more information on Vasculitis Awareness Month on the VF website and through our social media channels. So we really hope that you will join us in raising awareness. And then one project that we have going on right now is our Victory Over Vasculitis Join VF Team Brandon. Brandon Hutchkins is an Olympic hopeful. He is training for the Olympic trials, which will be held in July. Brandon is a long distance runner. Last year he ran the mile in a 3 minutes and 59 seconds. He is also a patient with GPA Wegener's, and so he is an amazing individual. His campaign this year, he is working as an ambassador with us to raise awareness of vasculitis and the VF, and he is just an incredibly motivating person. So if you go to the VF website and look for Team Brandon in the menu bar or just Google Brandon, you can learn more about our project. But basically we're asking people to join in, helping us with Brandon to encourage him to train for the Olympics. We're all training with him, and we're either doing a physical activity and or doing an awareness activity every week. So we hope you will join us for that. And thank you again for joining us today. Have a great day.